Hello, I'm Dr. Tymwa Dixon, and I'm a family physician with the Willis-Knighton Health System for 20 years. The following slide presentation focuses on pertinent issues concerning church reentry during the COVID-19 pandemic. The following article is from the May 19th edition of the Washington Post, but the same story was featured in several national publications. 2 churches reclose after faith leaders and congregants get coronavirus. The first church was Catoosa Baptist Church in Ringgold, Georgia, which reopened April 26th. After several families tested positive for coronavirus, the church was forced to reclose. The second church, Holy Ghost Catholic Church in Houston, Texas, reopened on May 2nd, 2020. On May 13th, the priest, Donald Kirchner, age 79, died, and on May 18th, masses were canceled. This is what the church does not want. So the purpose of this presentation is to review the characteristics of COVID-19, to review the effects of the pandemic on individuals and the state, to use our current understanding of the virus to guide our decision making, to identify and provide options for reentry for worshipers into the facilities, and to start to formulate a plan for the safest path forward. This is a brief timeline of the COVID-19 pandemic, which was initially reported to the World Health Organization on December 31st, 2019. By January 30th, the WHO had declared the COVID-19 outbreak a global health emergency, and by March 11th, a global health pandemic. On March 22nd, 2020, the governor of Louisiana, John Bel Edwards, issued a stay-at-home order. So the following graphic shows Louisiana COVID-19 cases in the state. As you can see in the top left-hand corner, as of the week of May 18th, there had been 35,316 reported cases with almost 2,500 deaths. This slide gives additional data on COVID-19 deaths in Louisiana, including racial breakdown and comorbid conditions associated with coronavirus. If you look at race, over 55% of those who die from COVID-19 are African American, compared to 42.62% of whites. If you look under on the right-hand column for comorbid conditions, we can see that hypertension is by far the condition with the highest association with COVID-19, and that's followed by heart disease and lung disease. On May 15th, the state of Louisiana under Governor Edwards started the process of easing business and social restrictions imposed due to the coronavirus pandemic. This included easing the restrictions on faith-based organizations and reopening places of worship. According to the Phase 1 easing of restrictions, churches may reopen at 25% of their occupancy, and churches may continue to conduct outdoor services not limited by 25% of their indoor capacity, so long as strict social distancing is practiced. So in reopening places of worship, we should be aware that until there is a vaccine, there will be some risk with reopening. The church should have a plan for reopening that is based on the best data and science available. And the Centers for Disease Control has recommendations for faith-based organizations that we can use to guide our decision making. So options for faith-based organizations include waiting for a vaccine or starting reentry with mitigation strategies. And what we mean by mitigation strategies is a protocol that is available to lessen the impact of COVID-19 on the church and its continued operation. So let's look at vaccines for a minute. Typically, it takes 10 to 15 years to produce a vaccine. But because of this current public health emergency, the National Institutes of Health, and pharmaceutical companies are attempting to produce a vaccine in a fraction of the usual time. Experts predict that it may take 6 to 18 months to produce a viable vaccine. So with vaccines, you first start with phase 1 vaccine trials, which typically checks for safety, and with vaccines, it checks to see if the vaccine elicits an immune response. This usually involves enrolling dozens of volunteers. One of the first vaccine makers here in the United States, Moderna, reported some promising results with its phase 1 trials with a vaccine against the novel coronavirus. How does the disease spread? So the disease usually spreads from person to person by respiratory droplets produced when an infected person coughs or sneezes. These droplets can land in the mouth and nose of those nearby, or possibly be inhaled into the lungs. Symptoms usually appear within 5 to 8 days after contracting the virus, but may appear anywhere from 2 to 14 days. Symptoms include fever, cough, shortness of breath, but may also include headache, nausea, loss of sense of smell or taste. Some emergency symptoms to watch out for are difficulty breathing or severe shortness of breath, persistent pain or pressure in the chest, new confusion or inability to awaken, and bluish discoloration of the lips or face. All these symptoms are caused by lower than normal oxygen in the blood. An important factor in the spread of coronavirus is individuals who are without symptoms and can spread the virus. This includes those who may never exhibit symptoms and those who may eventually exhibit symptoms but are early on in their disease course. The CDC recommends wearing cloth face coverings in public settings where other social distancing measures are difficult to maintain, such as the grocery store. So, the overall risk of death from coronavirus may be as high as 2 to 3%, but may be significantly lower based on the fact that there are many individuals that have very mild disease courses and haven't been tested for illness. The patients with the greatest risk of death appear to be those over the age of 80, with a death rate of as high as 15 to 20%. The risk in children of contracting the virus and dying appears to be very low, although there have been some new reports of childhood illnesses that affect the blood vessels and the heart. And the risk of a pregnant mother transmitting the virus to an unborn child appears to be very low. The risk also is higher in those with underlying chronic medical problems, as I mentioned earlier. This includes the chronic lung disease, such as COPD and asthma, and those who are immunocompromised either by inherited disorders, acquired disorders, or by medications that suppress the immune system. There appears to be a higher COVID-19 risk in African Americans. This may be due to several factors. Those include a higher incidence of risk factors, lower access to healthcare resources, and differences in treatment compared to Caucasians when the healthcare resources are accessed by African Americans. Some research suggests that droplets coming from normal speech may be harmful in transmitting the disease also, even from people who aren't showing symptoms. One study suggested that normal speaking in closed environments such as a home or a restaurant can contribute substantially to the spread of COVID-19. The study showed that 2,600 droplets are expelled from a person's mouth per second, and there may be as many as 1,000 virus-containing droplets that could float in the air for as long as 8 minutes. Researchers aren't quite sure if these particles coming from normal talking, and breathing are more infectious than droplets from coughs or sneezes. So what is the viability of the SARS coronavirus 2 in the environment? Research shows that the coronavirus can exist in aerosols for up to 3 hours, on the surface of copper for 4 hours, on cardboard for up to 24 hours, and on stainless steel and plastic for up to 2 to 3 days. So taking all those factors into consideration, when should we attempt to re-enter the church? Number one, after receiving approval from church district officials. We should not attempt to re-enter until we have gotten the proper permission. Number two, after the appropriate period of observation. There are currently many churches now that are attempting to open their doors and allow congregants back into the churches, and we should learn from their experience. Also, after formulating a viable reentry plan and communicating that reentry plan to all involved, to congregants, to church officials, and to other involved parties. Also, after identifying a cleaning team and obtaining appropriate cleaning products and a cleaning schedule. We should strive to protect workers who clean and maintain our religious facilities from exposure to the virus. Also, we should make sure to protect them from workplace hazards such as disinfectants and cleaning products. There are some cleaning products that should not be mixed, such as ammonia and bleach. Also, you should use any necessary personal protective equipment, such as gloves, when needed. We have to consider recommendations from the Occupational Safety Health Administration and the CDC cleaning and disinfection guidance. We need to start with everyday preventive practices. Clearly communicating to individuals to stay home if they're feeling ill. Also, clearly communicating that we should throw away any used Kleenex and tissue. We should wash our hands with soap and water for at least 20 seconds. And if soap and water are not available, we should use hand sanitizer with a minimum of 60% alcohol. We also should avoid touching our hands to our nose and mouth with unwashed hands. We should screen worshipers upon entry to the church. This can be done using touchless thermometers to screen their temperature to make sure it is less than 100.4 degrees. Also, we can identify those without a mask and provide one. Also, we should have an entry checklist at the entry of the church so that those entering can read and be reminded that if they are feeling ill, that they should not enter the facility. Also, we should consider alternative greetings. Greeters at all gatherings should refrain from offering handshakes, and they should model their hospitality with words and their smiles. We should recommend that members not hug or touch, and recommend that they use hand signals like a peace sign or the American Sign Language for I love you. Some strategies for social distancing include assigned seating. And seating should be assigned by household and not family. Younger congregants who live separate from older family members should maintain separation in the church. Again, we should limit social greeting, and we should have controlled entry and exiting. Not everyone should be trying to enter at one time or exit at one time. We should use alternative and overflow spaces for extra space. And we should continue to use Zoom and Facebook Live for those who are at highest risk. We should also address bus transportation because it is difficult to maintain social distancing on a bus. We can also reduce unnecessary announcements and speaking. We can make posts of our announcements on websites, on social media, by email, and by apps such as GroupMe. We should require masks of everyone over the age of 2 years old. And again, we should keep extra masks on hand for those who arrive without a mask. We should consider avoiding live singing, and alternatives could include the use of live instrumental music and pre-recorded singing. All of these factors can reduce the production of respiratory droplets. We also need to change rituals to reduce the spread of the viral infection. We can drain baptismal fonts, holy water stations, and vessels used for ritual washing. We should also consider canceling communion or at least placing prepared communion sets in the pews. This would decrease the chance of multiple people gathering in one location. Also, we should limit the preparation and the serving of food. And the occasion may come when we may need to address someone with an acute illness. So we need to identify a space in the facility to separate people who may become sick and may not be able to leave immediately. So we have to designate a separate bathroom for those who are feeling ill, and we need to develop a safe plan for cleaning the room regularly, especially after someone who is sick has been in the room. And we need to arrange for them to leave as soon as possible. Some methods for decreasing the chance of virus spread include limiting the use of the sanctuary except for Sunday service. As we know, the virus will die on surfaces if left for a specified period of time. Also, we can frequently clean and disinfect surfaces. We also should keep disposable gloves available for counting of money and for the cleaning team. We should avoid the use of printed bulletins, and we should keep cleaning products available in the restroom. Also, we should consider using some of the giving apps seen on the screen to decrease the use of cash. These include Givelify, Tithely, and Cash App. Also, we should consider delaying return for those at the highest risk. Those include the immunocompromised, those with uncontrolled chronic disease, and those who are over the age of 80. We should also consider strategies for maintaining good mental health during this period of time. We have to acknowledge that this time is one of heightened stress and anxiety. We need to respond with practices appropriate for our organization's mission and faith tradition. As always, we should pray, and we should refer to a mental health professional when appropriate. Some strategies for effective and accurate communication with members include ensuring community contact lists are up to date, conducting care visits by phone or virtually, especially if the individuals are in quarantine or in isolation or are taking precautions by staying at home. We should have calling trees or other practices in place to account for individuals who may be living alone, including the elderly and the vulnerable. And we should plan ways to continue essential services if on-site operations are scaled back temporarily. We should provide web and mobile-based communication services if possible, and increase the use of email, video calls, video conferencing, and web-based services. Faith-based and community leaders are valuable sources of comfort and support for their members and communities during the presence of the COVID-19 pandemic. These leaders are in a position to address concerns, fears, and anxieties regarding COVID-19. They can reinforce simple hygienic practices and precautions, and they can promote helpful information, manage fear and stigma, and restore a sense of calm into the lives of those in their care. Leaders can reach vulnerable populations with essential information and assistance. These acts of service are an essential part of the safety net for vulnerable communities. It is essential that we stay informed of frequent updates about COVID-19 virus. We can use the CDC website and the Louisiana Department of Health and Hospitals. We should use all this information to our advantage so we can safely re-enter our houses of worship. Thank you for listening to this presentation.